Okay, so we're going to continue with the same theme, and we're going to change gears a little bit and talk about the Alveolar Air Equation. And again, I want this presentation to be as interactive as possible. So I'm going to give you a case. We're dealing with a 58-year-old female who developed ARDS after a hysterectomy that had massive bleeding and required a lot of blood. So now she's being weaned from mechanical ventilation. Fortunately, this stopped working. So these are the blood gases. pH 7.4, PCO2 36, PO2 216, FiO2 65. The vent settings, assist control, pressure control. These are the total volumes. Again, I'm not going to concentrate here on the mechanical ventilator parameters per se. I want you to look at this. So what do you think? How are those blood gases for this patient? Do they look adequate? Anything that you want to change? So the first thing I would say, do you need a PO2 of 36? No. Why are you blowing so much CO2? So if you really want to protect the lungs, we need to do permissive hypercapnia. So that's one of the first things that you should be jumping at. And what else do you want to do? Tell me. I want to hear it.
Decrease FiO2.
You bet. Okay, so that's fine. So I'm rounding with you in the morning. We're making rounds, and I said, how low do you want to drop your FiO2 to? Give me a number. You're giving the orders now. 40. Any other numbers? So you just basically change the thing and then see how the pulse oximeter goes, and that's a if you ask me, that's pretty lame. Okay? Because in a lot of places, not just the SAT, you go through the SAT, but people get a blood gas as well. So every little change you do goes accompanied with a blood gas, and it takes 20 minutes to give you all these reasons. Oh, we're going to do it before that. A lot of stuff that's probably not even worth discussing, but it takes forever. So can we do something better than that? Can we be much more quantitative when we do this type of things? And the answer is, yes, we can. So yes, I would agree that the FiO2 should be the first thing I would drop. Okay? And that's why we're going to go through the Alveolar equation to predict this. Okay? I always said people can do a lot of things with their personal life, if you ask me. One of the things that I've noticed is that some of my residents do have tattoos. Okay? And one of the things that I tell them, I'm fine with that. You can have your tattoos, the ones that I can see at least. But one of the things I always tell them, if you really want to have a good tattoo, okay? If you ask me, this is what you should be wearing. I'm serious, because I ask, and I'm going to prove to you how important this equation is. So I always encourage them, you don't have to show me the tattoo, but at least get it on your body so you'll see it every day. Because this is critical. This is how important this whole equation is going to be. I'm going to prove it to you. So let's go start dissecting this. Let's talk about FiO2. Okay? So FiO2 is easy. You go up and down. You can give supplemental oxygen. You have all kinds of different things, a face mask, and non-rebreathing. You can tube it and go up and down. So that's not a biggie. That's easy, and that's why it's so easy for us to manipulate this. That's why you feel so comfortable dropping down, whatever. You don't even care how much. You just go a little bit or more, whatever, depending on how aggressive you are, that kind of thing. Okay? So my question to you is then, you have, this is South Beach. What's the concentration of oxygen in Miami? And what's the concentration of oxygen in Everest, which happens to be at 29,000 feet? And the answer is? Give me a number. What's the concentration of oxygen in Miami? 21%. How low does it get in Everest? 21%. So you're telling me the concentration is the same? What's that? Sure. Is that the question I asked you? I asked the concentration of oxygen. Is that correct? It's the same. Now I'm getting confused. It's the same. Barometric pressure goes down. So concentration is there. What if I tell the concentration is different? Let's go through this, okay? Because this is very important. One of the things that we do is that we use a fraction-inspired concentration as a way to express concentration. What I mean by that is you count 100 molecules and you see how many of those 100 are oxygen. If you do that in Miami, you do that in Everest, the ratio is the same. Guess what? 21% of the molecules you have in Everest of air basically are oxygen, the same as in Miami. But look at the package. That has to do with the barometric pressure. They're much more concentrated in Miami because of the barometric pressure compared to in Everest. And concentration is a unit of mass per unit of volume, okay? And that's what you get here. So if you look at the amount of concentration of mass per unit of volume in Everest, then you have to conclude that there's more concentration of oxygen in Miami than in Everest, okay? If you express the concentration in FiO2, so the fraction inspired, that's a different thing. They're basically the same, which is, as clinicians, we tend to simplify things and think about it. Most of our living happens very close to sea level for most of human population. You're not supposed to be living in Lake Titicaca in Bolivia, which is 4,000 meters high, or up in Everest. You're supposed to be living in the coast, you know, near the water, etc. So FiO2 happens to work for the most part very well, but you have to understand that there's limits to that, and in scenarios where the barometric pressure changes, that's when you have to start thinking a little bit about some of these issues. So the parameter that you should be concentrated on should be the partial pressure of oxygen, because that's what really determines the flux of oxygen through the tissues, the partial pressure of the agent. That gives you, if so you will, the chemical activity of the compound going through the tissue as a concentration gradient. And you can tell the barometric pressure in Everest is a third of what it is at sea level, it's 250. So when you look at the numbers and you look at the P inspired, the partial pressure of oxygen inspired air in Everest, look at what we get. Okay? You subtract the water vapor and it goes down to 40. So the environmental, the air that gets into your lungs will have a PO2 that is close to 40. And this is without the dilution of your CO2 that you're going to get as well. That's why when I was telling what are the PO2s of people climbing at Everest without oxygen, it has to be below this. Okay? And that's important to understand. But again, partial pressure is the most important parameter, if you ask me, more than the FiO2. Okay? And we went through this. And this is the paper that I was telling you about, 2009, Rockert and colleagues. They did the measurements, okay? And you can tell, 24.6 is the average, 29 and 19, okay? Interesting enough, Reinhold Messner climbed Everest without supplemental oxygen. So imagine climbing this thing. The exercise that takes with PO2s that are probably in the mid-20s is just incredible. Again, these people have had long exposures to hypoxemia. These people have had a lot of adaptations. As we were talking before, this hypoxia over time probably brings enzymatic changes and other things that we sometimes don't understand. Okay? But again, if you want to express the concentration, this is what we have. 7.7 millimoles per liter and 2.7 millimoles per liter. Okay? So again, when we're rounding and I ask you, what's the concentration of oxygen this patient is getting? I don't want to hear 22, 32%. I want to know how many millimoles per liter this patient is getting. Is that clear? Because that gives you a better understanding of the concentration of oxygen that the patient is getting. So FiO2, again, is easy to manipulate. You have to understand the relationship between that barometric pressure and the partial pressure that this generates. Okay? Well, let's talk about this. What's this? This is Apollo 15, probably. Okay? This is the what they call the command center, and this is the service center. You know, part of the setup that they have to go to the moon. Okay. Do you know what's the oxygen concentration that NASA used for their astronauts? 100% oxygen. Okay. So astronauts were sent to space in 100%. Okay. And they spend days into this oxygen mixtures, you know, and knowing you guys, I know you're going to be very worried about this. Why would they send people? Highly trained individuals. You know the cost of an astronaut? Probably in the millions. Now you send this guy up in space in 100%. So there are two options. Either NASA doesn't care. Think about it. For the sake of space exploration, the advancement of humanity, science, etc., a few people A few individuals go up in space, they get a little bit of lung injury, who cares? That's one option. Okay? Or there may be something else happening. Okay? How can you afford to send these people in 100% oxygen? So the answer is that the pressure inside the capsule is below atmospheric pressure. It's a third of an atmosphere. Okay? So now you have the scenario that yes, you may have 100% oxygen, but it's a third of an atmosphere. That gives you an inspired FiO2 of partial pressure of 350 millimeters of mercury. And guess what? Oxygen toxicity is a partial pressure dependent phenomenon, not an FiO2 phenomenon. It's a partial pressure. So whatever combination of barometric pressure and FiO2 that you have that give you a partial pressure of 350 or higher, that's when you get toxicity. Okay? So guess what? You can afford to be up in space like that and not having toxicity. And the real reason is that by having the system pressurized to a third of the atmosphere, you can make those systems thinner. What I mean by that is that you are dealing with the transmural pressure of the capsule and basically space, or void basically. So anything that increases the pressure inside, or the higher the pressure inside, the thicker the materials have to be to withstand the pressure differential. The heavier the spaceship is going to be. And as you probably know, it's very expensive to send stuff up in space, and the amount of fuel you're going to consume depends on that. Okay? So that's a big problem, and that's why initially the thought process was to try to make things thinner by lowering the pressure in the inside. Okay? And again, this is what we talk about transmural pressure, and this concept of transmural pressure applies in many other things in physiology, your heart, your lungs, etc., etc. And again, to go up in space and get a pound up in space, this is what it costs, between $12,000 to a $20,000 cost to get a pound up. So again, very important. The problem, though, of having an atmosphere so rich in oxygen is this. I don't know if you remember, but this is Apollo 1. They're basically, not even on the launch day, I think it was a day or two before the launch pad, they were doing a test for a potential launch, and a little spark happened in the middle of the setup. They already had closed the latch, and these people burned alive. They couldn't take them out, it was too fast. So I don't know if you've seen, have you ever gone to this Smithsonian, you've seen all these LEDs and things, you have a little spark in those things, boom, you have 100% oxygen, it's a disaster waiting to happen. So that's what happened. That's why the Gemini and the Mercury programs use 100%, and the Apollo initially, the whole idea was to use 100%. But that proved to be very, very dangerous. So oxygen toxicity is one of the things that we talk a lot about, and again, you have to understand that the oxygen toxicity, for one, is time dependent, but it's also species dependent. If you happen to be a rat, you can have ARDS within 24 hours. Humans behave different, though. In order for you to get something similar to ARDS or acute lung injury, you need probably a week of exposure to 100% FiO2. Normally what happens within the first 24 to 36 hours, you get tracheal bronchitis, you get irritation, start coughing and feeling a kind of a retrosternal discomfort. Okay? So, and again, it's rare for us to keep people on this FiO2 for so many days. Actually, there's a limit. If you give people too much oxygen, and the example would be when you put them in hyperbaric environments where you can actually go to 3 atmospheres and 100% oxygen, then the oxygen becomes toxic on its own. Not that it's something that will take days to develop. These people start having seizures. That's why you don't go any higher than that. I think the combination of oxygen and the environmental pressure goes to 2.7 when you do those dives. They call it dives when you go into the hyperbaric environments. And you can get acute seizures. So oxygen toxicity is a partial pressure dependent phenomena. Again, anything below 250 is okay. Yes?
A lot of people talk about, keep them off the FiO2 of 100% in the ICUs, limited to maybe about 7 to 8 hours. So you're saying that it isn't until 7 days they start to develop some toxicity?
Yeah, for lung toxicity to be manifested clearly. The reason, in the ICU you have to deal with the following though. You're dealing with patients that are sick that have lung pathology, okay? So they're already inflamed and they probably have all kinds of oxidative radicals all going over the place. Now you couple this lung that may have been injured already, and you add the high FiO2. So I would say yes, a few hours on a high FiO2, is that deleterious? Like everything we do in medicine, I think if we can avoid it, we should. I think there's definitely an oxidative load to the body when you do that, oxidative load to the lung when you do that, and you might want to stay away from it. Think about the way I view this is that you tend to do cumulative damage to the body. What I mean by that is that, yes, you do a few hours of high FiO2. This patient had an ARDS because he was transfused, to give you an example. And then he happens to be anemic, and we give him another unit of blood because the attending is uncomfortable. The surgeon feels that, oh, a crit of 24 is too low. And they decide to give blood. So now you're adding all these different injuries to tissue, including the lung, and then you have a disaster. You get a lung that will never recoup. So if you ask me, yes, I think the lower I can get, the better. I think SATs in the 90s are perfectly acceptable. A PO2 in the mid-50s, low 60s is all you have to aim for, if you ask me. That's enough to live, enough to recoup, and hopefully will reduce the oxidative load to the body. Does that answer your question? But again, very species dependent and also time dependent. Again, all of us do this. In the OR, we sometimes put them 100% until we do things. Sometimes we forget. And I've seen patients being 100%. You can have reabsorption atelectasis on top of it. A bunch of little things that can happen on top of it. Remember, you've been designed to live with 21%. So 100% FiO2 is huge. It's huge. So talking about gravity, what can you do to affect gravity? One of the easiest things to affect gravity is to move to another planet. And again, if you start choosing which planet you want to go to, I think Jupiter is the only one. Let's look at the relative gravity of Jupiter compared to Earth. It's the only one that has a positive number. So you have your ARDS patient. So instead of proning the patient on doing ECMO, which we talked about this morning, send to Jupiter. Very easy. You know, you have to do nothing, and it's not too high. It's not too high. So I think you will reach a good PO2. Very similar to what we do in hyperbaric environments too. It's very awkward when you have to deal with patients in a hyperbaric environment because of the access thing, and you cannot keep them there forever. So hyperbaric treatments are not designed to treat people with ARDS, so that's kind of impractical. But changing planets could be an interesting thing. Let me give you an example of a set of experiments that we end up doing. And I happen to be the medical advisor for the group of experiments. We had pre-med students that the idea is to see how much they could run under a hypoxic environment. Okay? So the whole idea is to put them on a treadmill and to create a system with big reservoirs, balloons that had low FiO2. So they would run, and we would see how much they could run for. The FiO2 was basically 10%. This is a protocol that has been tested to be safe. You know, we were replicating a protocol that's been published in the literature. So you read the paper, they did fine, whatever, this is an established protocol, let's do the same. So we did that, okay? And we took some precautions. We basically had a harness on those students in case they felt weak or whatever. We could retrieve, you know, all the things that you would do. You don't want to kill those medical students. They're getting paid nothing to run on this treadmill, okay? So we do that. We put the first kid on the treadmill. He starts running, and within 20 to 30 seconds, the guy starts like falling apart. He almost collapses. When we took him out of the thing, he was almost seizing. So I had to get an ambu bag and revive the kid. Okay? That's no good. And I'm the medical overseer of this whole thing. Okay? And we're not in a hospital, we're in a lab in the middle of nowhere. Okay? So that's bad. So what do you do when you see this? When this happens to you, what do you do? What's that? Well, but that defeats the purpose. Defeats the purpose of the thing. Oh, the kid came back right away. It's a kid. You know, give him a couple of puffs of oxygen, wake up. Oh, what happens?
The next one.
What's that?
Give us another one.
Yeah, actually, we did that. Before we did that, we said, let's check what's going on. Something went wrong. You know, remember, we fill these balloons we create our own mixtures, okay? So we bled nitrogen into balloons, and we measure whatever, so we check everything. Are the balloons okay? Are the valves you have to have one-way valves to get the air in and out, whatever. Are the valves stuck? Are we creating? No. So we went through the whole thing. We calibrated our sensors. Everything was fine. So I said, everything looks good. Let's get another kid into the thing. So we did. The second kid lasted probably a little bit longer, but he started stumbling. As soon as we noticed that, we took him off. Again, not as bad. We didn't have to give him a ambu bag or resuscitation for that matter, but it wasn't good. Okay? We review everything again. Check the concentration. We measure everything. Everything is good. Okay? So, you know the Alveolar Air Equation very well. Okay? So the other thing that could explain this thing is the barometric pressure was low. So we called the weather station to see what was the local pressure. Okay? And the pressure was 736 instead of 760 or 765. We have a low pressure system going through the area at that time. It sounds stupid, but when you're dealing with 24 millimeters less and you're dealing with FiO2s that are very close to Everest acutely, it can make a big difference. Okay? It's one of those things that it sounds funny. I remember looking at this, and it occurred to me, the only thing that can be wrong is the barometric pressure, like a joke. Like, you know, or the gravity or the earth change that day. Those are the two options. Between the two, I go for the barometric pressure thing. And it was low. Okay? So we redid the experiments the day that we had normal pressure, and it went well. And it went well. Again, a testament to the fact that the Alveolar equation is such a powerful tool. But again, what other issues can we have with barometric pressure? So, what's the lowest point on Earth that you know of? That is not a, it's a Dead Sea. How low is that? It's a little bit lower, but the interesting thing about that is that the barometric pressure is higher. It's 423 meters, okay, which is 1,300 feet. That's fine. You're excused.
Last time I was there.
I understand. Have you been there? Have you been there? So, did you take a bath on the? Exactly. And I don't care about the salt. What? Isn't there medicinal things associated with the water and where they sell the water and everything?
The mud.
You couldn't afford.
It's the mud that you put
the
on.
The mud, yeah. And you can scrub or whatever. If you can buy those things here, it's very expensive. Water from the Dead Sea, whatever makes you. This is all these magical properties of the water of the Dead Sea. Really? Really? So, what it is that because you're below sea level, the barometric pressure is close to 100 millimeters of mercury. So you have to feel great. You have oxygen everywhere. So when you get a COPDer, for example, that is very limited and exercise capacity, you get them to the Dead Sea, you feel like great. When they do exercise testing on those guys, they perform beautifully because now they have oxygen. So all these beautiful things about the Dead Sea, how miraculously you get better and you heal and your skin looks good and all the things that they will tell you, have to do with oxygen, have to do with barometric pressure that's higher than normal. So don't get fooled. I'm glad you didn't buy the water to begin with. Let's talk about airplanes. Who knows this airplane? You bet. What's the beauty of this airplane?
High altitude, high speed.
You bet. It's so unfortunate they took this out. You know, this is old technology. I think the Concorde was designed like in the mid '60s, and it came into being like in the early '70s, and it was flying up until early 2000, 2003. I don't remember. They had a crash. Remember, not long ago, taking off in an airport in France. Something got into the engine and it kind of exploded. And after that, that was 2000. I think in 2003 they decided to take the plane down. Again, very expensive, very impractical, but it was a beautiful thing because this thing could go up to 2.02 Mach, which is a percentage of the speed of sound, and it was supersonic flight. So you can be in New York, London in, I don't know, 3 hours, something like that. And the beauty of this is that it was British Airways and Air France, okay? So if you happen to take the Air France plane, they would treat you like royalty. Okay, you would get to the VIP lounge. This is first class, everything is first class. You sip your champagne, the hors d'oeuvres, the whole thing. What a wonderful thing. And you jump into this plane, okay? You jump into the plane, all of a sudden you start having abdominal pain, you don't feel good, then boom, you collapse. What happened? That's when you get scared. This is when you're in a, in a plane and you hear, is there a doctor on board, whatever, you say, no, 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 it's not gonna be me. That's the type of thing you don't wanna hear, okay? So, what happened to this poor fellow that was having such a wonderful time? That's a good question. Was he in the Dead Sea scuba diving? I don't know. Could he be drunk?
About champagne and the carbon dioxide in the champagne.
Correct, that's a big problem. So when you basically change pressures, and the thing is that you have to understand that these cabins are pressurized, but they're not pressurized to sea level. They let them go up to equivalent pressures of 8,000 feet, okay? That's why, so again, it's part of the transworld pressure gradings and that sort of thing. It makes it easier. That's one of the reasons you feel crappy when you fly. I don't know if you've noticed. Some people feel like distended bellies, and I don't know what's happening here. The food, for one, they don't give you food anymore, so people don't feel it anymore. But in the good old days, you get a tray and you would eat and say, oh, this. So you know, guess what? Your gases in your body were expanding. So someone who has all the CO2 bubbles, whatever, still that expands, and you can have a vasovagal syncope from expansion in the stomach. Okay, well described. Actually, pilots have to have their cavities fixed because little air bubbles and those fillings, whatever, if they're not well corrected, they expand and they produce excruciating toothaches in the middle of air. That would be kind of nasty to have a pilot with toothache trying to land. That would not be nice. But for example, the Concorde used to fly, as you said, very high. And the reason it flew very high is because they had to reduce resistance. The speed was so fast that it would warm up too much. So you have to fly at a higher altitude. So if something bad happened inside the plane, you have to have little windows. One of the interesting features of the Concorde is that the windows are tiny. So that's why they compare it with a Passport compared to the normal ones that you have. And they had to do with that. If there is an acute decompression problem, you have to reduce escape of gas, at least minimize it by having smaller windows so they have time to go down, okay, to save the plane. And commercial airplanes fly, I don't know, 35,000 feet, plus or minus. Sometimes they go. Yesterday, coming on my way here, there was so much bad weather that the pilot took the plane to 39,000 feet. I said, okay, that's good. That's kind of on the highest level. But if you look at what the Concorde does, they fly at 60,000 feet. They used to fly at that height. And look at what is interesting. At 65,000 feet, the environmental pressure is 47 millimeters of mercury. Okay? So what's interesting about 47 millimeters of mercury? It's a peculiar number. What's peculiar about 47 millimeters of mercury? Water vapor pressure. When the environmental pressure equals the vapor pressure of a liquid, boom, the thing will boil. So this plane is so close to basically, if you get exposed to the acute environment, you're going to boil. It's very cute that those oxygen masks will drop down, whatever. You're basically boiling as this is happening. Okay? It's not going to help you. Okay? It will help you, and I think I have, when you're at 40,000 feet and you breathe those masks, yes, you can have a PO2 that is decent. You can survive. When you're at that height, you're counting on a pilot that can bring the plane down, so you can survive. And those pilots will have, you know, like the jet fighter pilots that have all these features and stuff. They have to do that because this is very close to altitude that is very, very dangerous. Okay? And again, and this is stuff that you say, well, why do I need to know that? For one, you need to know why you feel so crappy when you go into a plane. But you may have a patient. Let's say I have a bad meal tonight and I get intoxicated with some toxin, whatever. I get very sick, I get septic, I develop ARDS. So I'm stuck with you guys for 2 weeks. I get better. Now I need to go back to Miami. And the first question I'm going to ask you, can I fly? Can I take the plane back to Miami? And you need to know some of the stuff so you can do the calculation. Are the PO2 acceptable in someone who already has lung injury or bad COPD, for that matter? Okay, to travel on a plane that has pressure that's lower than normal environmental pressure. So these type of things, and there are tests to do this. Okay, you can look it up, and there's tests that you can do to see how patients will do. But this information you need to know because it's not trivial. Some people will not tolerate this. Okay, especially if they're very, very sick. Imagine doing the trip on car. You could, okay? And that's what I was saying. The CO2 expands, you get vasovagal, and that's classically described the same for the cavity fillings. Okay? So we talk about FiO2. We talk about environmental pressure. Okay? So what about water vapor pressure? Again, this parameter you have very little control of. If you think about it, this is a chemical characteristic of basically the fluid per se. And it's temperature dependent. So the environmental pressure can go up and down. This won't affect it. 47 millimeters as long as it's 37 degrees. So if you look into the Alveolar Air Equation, what's the problem here is that as everything is going down, let's say you're going high in altitude, and other things are going down because the FiO2 goes down, the barometric pressure goes down, this number remains the same. So it becomes a bigger portion of the whole thing. That can be a problem. Unless you become like hypothermic, you're in Everest, and now your body temperature, which can happen and will happen there relatively quickly, you go from 37 to 36 to 30, and then you can feel good about that because you know your water vapor pressure is going down, and you're going to probably die from hypothermia. So that's a problem, but so much you can do about that, and that's a fixed component there that you have basically very little input there. But let's talk about CO2 then. Okay, CO2 is a parameter that you can control to a certain extent. Okay, and the problem is that if you want to increase the total number here at the expense of lowering this, there's so much you can do. Okay. If people up in Everest, because of the chronic hyperventilation they have to endure, they have PCO2s in the mid-teens, and that's okay. But that takes weeks of adaptation. That's why your acid-base status changes in your body and that sort of thing. That's why some people need to get treatment when they go up in altitude. But you hyperventilate like crazy. But by dropping it to a low level, you increase this whole component by dropping this component here. But the other thing can happen too, where CO2 going up can be a problem. I'm going to give you an example. Vascular patient having a fem pop under an epidural. Okay, the surgeon that we're dealing with is very slow, so the patient gets uncomfortable. He gets sedated through the case with a propofol drip. Okay, we finished the case. The case went beautifully. 5 hours for a fem pop. I don't know how fast your surgeons are here, but we have some guys that will do this. Exactly. They train in the same place. So the patient arrives to the recovery room, and then 5 minutes later you hear over the intercom that the patient has arrested. Okay? As he arrests, you do an arterial blood gas. Okay? And the CO2 is 210. What? 210? Really? The only way you can accumulate that amount of CO2 takes time. Even if I just choke you and tie your trachea, it takes minutes for the CO2 to get to that level. Minutes or potentially hours. And again, this is someone who was still breathing, because normally they have the entire CO2, you see the curve, whatever, but after 5 hours of this thing, this guy had severely hyperventilated for so long that he basically had an arrest. Why wasn't that picked up anytime sooner? Okay? Because look at the Alveolar Air Equation. What's the first thing you do when you drop your patient in the PACU? Put them on oxygen. Okay? As soon as, let me see if I have some of the calculations here. So, as soon as you give him supplemental oxygen, this component here, let's say give him 100% oxygen for the sake of discussion. This component here is close to 600. Okay? The patient can have a PCO2 of 300, 400, and you will never see. The sats are beautiful. So the sats are good, the guy rests. Okay? Because of this. This plays, as you increase in this, there's a risk of not being able to pick up that. The pulse oximeter is not supposed to pick hypercarbia, that's for sure. Some people will say, don't give him oxygen, because if there's a problem with CO2, you'll see it. If you're giving very little oxygen here, room air, then hypercarbia will produce hypoxemia, and you pick it up. So are you willing to put all your patients without oxygen in the package? Just a question. Okay? So look at the numbers, very interesting. It has to go up to 613, the CO2 has to go to this level. So now your alveolar 2 is 100. So to become hypoxemia, it has to be even worse. So you'll never see it. The patient will die before you know anything. What's the highest CO2 level you ever seen? How much?
160.
Nothing. 150.
I've got 160.
That's nothing. Actually, hypercapnia is a good thing, isn't it? It's a wonderful thing. And you should get used to that. Okay, permissive hypercapnia is one of the things that is important. We're trying to, and acidosis for that matter is a good thing. Okay? Acidosis protects the tissues. It tends to block some of the pathways and mitochondrial entrance of calcium entrance into the mitochondria, et cetera, et cetera. So hypercarbia and acidosis, if you ask me, they're good. When I'm doing a case and the CO2 is high and my patient is acidotic, I just love it. Okay? Especially if I'm doing like one lung ventilation. Okay? Excellent. That's the way it should be. Okay? And we can talk about that if you have any questions on that, but I think that's a way to go. So what's the highest PA CO2 that you've ever seen? 501. This is published by Dr. Slinger, a very famous cardiothoracic anesthesiologist. There's a case report. This is a young kid, fell on a grain silo. His whole airway was filled with little grains, and they had to go with a rigid bronchoscope getting grain by grain out. As this was happening, they were doing apneic oxygenation. So they were able to oxygenate him well, and they couldn't ventilate him. And the CO2 went as high as 501, and he survived. So if you want to quote a good paper saying that CO2 doesn't matter for the most part, this one is one of them. So again, one of the things that you have to get comfortable with, particularly in the ICU environment, where you tend to get fixated with numbers. I think letting the CO2 go up is probably good. Letting the PO2 go down, and I'm not going to tell you what's the right number to go down to, because that's a question. It can be controversial, but still. So this is the type of things that you have to be familiar with. Last but not least, RQ, respiratory quotient. What does that mean? Respiratory quotient is something that is a ratio that we generate between the CO2 that we produce and the O2 that we consume. Okay? So basically that's derived from the type of fuel that you're burning in your body. Okay? When you burn fat, the quotient is close to 0.7. When you burn carbohydrates, it's closer to 1. In other words, when you have a very rich carbohydrate diet, you produce a lot of CO2 and vice versa. If it's more fat, you drop the CO2. I always say, if you have a patient and you're changing their diet to improve CO2, you're in trouble. Okay? When you start playing those games with the nutrition and let's get the high-fat mixtures in, whatever, you're basically in deep trouble. Normal. You don't normally do this for regular patients. Okay? And so much you can do. You can definitely, and this is an important parameter because, for example, you are in the ICU and you're feeding your patient. One of the things, if you could measure this routinely, and I will tell you, some of the new ventilators may have metabolic monitors that will allow you to do this. Actually, which anesthesia machine do you have here? Advance. Advance has a module produced by GE that allows you to basically measure O2 consumption and CO2 production. And it gives you an RQ in anesthesia. So when I'm doing my heart, I put the RQ very big, so the surgeon looks at it and he's like all confused. What does that mean? It's the RQ. It's a wonderful gadget to have just for that only reason. But you can measure it, and it's available. Okay? So again, so much you can do in terms of manipulating the number. But you can play with the diet. But trust me, it's a beautiful picture to see the confusion on their face when you tell them about respiratory quotient. And wow. So, let's go back to the original question, okay? The original question was, how low would I have to go in terms of dropping the FiO2 in my patient? Remember, we wanted to drop the FiO2. So we've been through all this, okay? But if you think about it, that's to predict what the alveolar O2 is going to be. But really, what I really want to know, it's the arterial O2. That's what I really want, not even this. So I'm still far away from this. I'm not even close. So in order to know what the arterial PO2 is, what is it that I need to know?
A gradient.
The A gradient. Exactly. And what's a normal A gradient?
10 and 20.
What if I tell you I have an A gradient of 100? Would you intubate me if I have an A gradient of 100? What's that?
Depends on what the FiO2 is.
Correct. That's totally correct. And the issue here is an isolated A gradient without knowing the FiO2 is meaningless. Okay? So, again, the A gradient should be very close or less than this, but the gradient can increase. And that's because, look at the behavior, exactly, it depends on FiO2. And look at the behavior of the PO2 and the alveolar O2 as we increase the FiO2. So as you go up in FiO2, of course, your alveolar oxygen concentration goes up. It also, the arterial concentration does go up. But look at what's happening here. The AA gradient is widening as you increase the FiO2. That's very annoying, if you ask me. Okay, it's one of the things that I see this is like, oh my God, something is not right here. Okay? I would like to have a setup where by going up on FiO2 will produce this. Wouldn't that be nice? So you can get an arterial O2 that parallels very close. So if the A gradient is 10 millimeters of mercury, then I have an alveolar O2 of 650. I can have a PO2 of 640, 630. That would be spectacular. But that never happens. The PO2s that you maximally get in humans is what, 500, 520? I don't know if you've done gases on people 100%, but that's what you expect because the A gradient is increasing. So why is the AA gradient increasing? Why do we have this inefficient gas exchange as you go up in the FiO2, if you want to call it that way? Let me give you the explanation. Again, remember this. This is blood getting oxygenated here. This is blood being shunted, not being oxygenated. I'm going to go back to that in a second. So, I hate the in-training exam and the board exam, whatever. I have issues with those little multiple choice questions that you have to answer every year. But there was one exam that I did that brought tears to my eyes when I saw this question. And I hope you can relate to this. So the question was as follows. I get a glass of water that is 100 mLs, PO2 of 100. I have another glass of water that the PO2 is 0. I mix them together. What's the resultant PO2? And you have, again, this is multiple choice thing. 100, 75, 50, 25. And you guys are very good at this. The answer is? Remember, you have all the questions to answer. You have a bunch of questions. So, what's the PO2 there? It's 50. It's no tricks here. This is very easy. I wasn't crying there yet, okay? But let me show you the following. We're going to do the same experiment. I have blood, PO2 of 100. Blood, PO2 of 0. Same volumes. I'm going to mix them. Okay? And again, the answer could be 100, 75, 50, and 25. D. Don't you have almost tears in your eyes when you see D? Why do you say D?
Because it's a P50.
Exactly. Whoever did this question, I don't know if we have any board reviewing or writing individuals here, because some of us will write some of these questions. This is beautiful. This is spectacular. This is very clever. Okay? So look at what's happening here. The answer is 25. So it's very interesting to understand that the effect of shunting in the lung, depending on the original PO2 that you start at, have a significant effect on the partial pressure gradient of oxygen. And let me go back again and see if I can explain this a little bit better, because it's not an easy concept. So this is your oxyhemoglobin dissociation curve. Okay? You have someone that, this is at 100. I'm adding 5% of deoxygenated blood to the same flask. To be 100, I add 5 cc's of deoxygenated blood. This has dropped to 95. So from PO2s, I can be, I don't know, 500. You can see when we reach 5% desaturation, the PO2, let's say, is 80. So we started with PO2 that can be, I don't know, 200. I add 5% of this saturated blood, the PO2 drops to 80. So I start at, I think I have the numbers here. Let me see if I get the number for you guys. So I start actually with 250. I add the 5%, the blood goes down to here, and it goes down to 80. So a little bit of blood, 5% of the saturated blood added to a very highly saturated or high partial pressure, because this is dissolved oxygen, produces a dramatic drop on PO2s. And it has to do with how shallow or flat this curve is on the top. So dropping 5% here produces a huge drop in this axis because of a flat curve. That should be very, very clear to you. But if we do the same, and we do it in blood, we add the same 5%, but we're starting with blood that has a PO2 of 26. And then we add the blood, and we drop it to 45. The PO2 drops to 21. Because the curve, this 5% drop from here to here translates into just a tiny drop in PO2. So you can see that the same percent of desaturated blood added to blood with different initial PO2s can have a dramatic effect on the resultant PO2 when you mix the blood. It has nothing to do with the content. Remember that content is a little bit different. And I'm going to talk about content. I'm talking about partial pressure of oxygen. So guess what? When you're dealing with a lung, that let's say you're giving a high oxygen concentration and there's a high PO2 here. When you give, and you normally have a certain percentage of shunt, when this desaturated blood mixes here, there's going to be a huge drop in PO2. That's why your gradient is basically widening as the FiO2 goes up, or vice versa. It narrows down as the, if you start at a lower level, if your PO2 in the arterial side is lower, and then you add the desaturated blood, the drop in PO2 is not going to be that important. The drop in content is the same. If you think about it, the drop in about 5%. Content-wise, it's the same. If you express it by partial pressure, which is what we always tend to think, it can be a huge dramatic change. So that's why, even though it sounds kind of very inefficient, the way the AA gradient behaves has to do with the behavior of actual hemoglobin more than anything else. So, what is it that you need to know? Okay? Instead of both curves going in parallel, okay, which is what it would be ideal to have, but we know that ain't happening because of how hemoglobin behaves, you have these two curves. The interesting thing is that these curves maintain an interesting ratio. The arterial to alveolar ratio in a normal individual is 0.8. So 80% of the partial pressure in the alveoli shows up in the, on the blood, on the arterial side, in the capillary blood, as a rule of thumb. Okay? So now you can start working backwards to determine, this is what you normally have. So the 80% of what's in the alveoli shows up in the artery. Okay? So now let's put numbers into the alveolar air equation, which was the original question. Okay? We have the patient on 65% oxygen, wasn't that the case? We have the CO2. We have the alveolar pressure of oxygen on this patient is 418. The arterial PO2, which you thought was actually very nice, and it is, 260 is actually too much. When you create the ratio between the two, I think the ratio comes up to 50%, 51%. Okay? Normally it's 0.8. Now we're down to 0.5, meaning you have an increased AA gradient. Okay? So independently of what your AA gradient is, when you look at the ratio, then you can tell if the patient has a problem of gas exchange or not. Okay? And then you can substitute other numbers. Okay? You're aiming for a PO2 of 60. The ratio is 0.5. So now you have to solve for what alveolar PO2 do you want. When we do that, it's 117. When you plug in this number in here and you solve for the FiO2, you have the other numbers, you're basically getting that the new FiO2 that you need to is 22%. So when I'm rounding with you guys and I ask you what's the FiO2 that I want to do, I'm hoping that early morning you should have done all the math and Dr. Martinez is going to be 22%. I said, wow, go for it. And the PO2 is 60. Then we don't have this, I'm assuming you're going to be changing the breathing rate so you don't have a CO2 36. You're doing all kinds of things, because I went berserk when I see all those numbers in the morning. So you need to drop the FiO2. I'd say 25, you're going to be generous. 25% FiO2 would be my goal. And you definitely want to change the rate so you can increase the CO2. Okay? So I think it's very important. I think you need to understand this equation. It has implications for your life, for the people that you treat, or the students that you subject to experiments without their consent, and things like that. Okay? So it's important for you to know that this equation is critical. Okay? I think it's very important to understand how the A gradient behaves too, and it has to do with the oxyhemoglobin curve, which I think is a very important concept. And I think at the end, I convince you that you need to get this tattoo. Thank you very much. Any questions?
I want to ask you a question about the PEEP. You will drop the PEEP first, or
No.
you will, I mean, what you will do?
Oh, PEEP remains high.
As a PEEP, no other side effects of the PEEP. What do you think you're
Minimum.
going to continue?
Yes. The concept of PEEP is very important. I do think we under PEEP our patients. Okay? It is clear to me that when your PEEP level is insufficient, you're going to de-recruit alveolar units at the end of exhalation, and then you're going to open them up again with the next breath. So you're going to have units that are basically going up and down. We call that like flap trauma. Wattelek trauma is the right term. I like flap trauma is better. But and these units that are being recruited and de-recruited are going to be damaged. There's alveolar rupture and breakdown, and this produces inflammation. So low PEEPs are bad. Okay? I would say most patients tolerate higher levels of PEEP in terms of hemodynamics and venous return, all that stuff. So if you need to go up on PEEP at the expense of giving a little bit of fluid, that's okay with me. The problem would be, so what's enough PEEP? How do I titrate my PEEP so I get the right amount of recruitment without over-distending the alveoli? And that's a very tricky question. I will tell you, if you ask me, I would like to have what is called transmural pressure gradients. There's esophageal balloons that you can fit on your patients from the ventilator, and you get what is called a transalveolar pressure gradient. And that's the ultimate way to titrate PEEP, if you ask me. When they've done the studies where they titrated the PEEP, not to the, a lot of people use the ARDS network tables. When you have someone sick, they see, oh, this is the PO2, this is the FiO2, boom, this is the PEEP that you have. When you do management of PEEP using those tables versus management of PEEP using transpulmonary pressure gradients, you will notice that the patients managed with the transpulmonary pressure gradients have higher PEEPs, but they also have higher PO2s, shorter length of stay on the ventilator, and potentially a mortality benefit. Okay, New England Journal, the people from the Beth Israel proved that those patients did better if the titration was done by a physiological parameter based on recruitment of the lung than by just tables alone. So yeah, I'm a believer. PEEP is the last thing I usually win on my patients, if you ask me. Well, thank you very much. It's been a pleasure.